I am going to introduce to you Dr. Jessica Young. She is a graduate of Vanderbilt University School of Medicine. She joined the Vanderbilt faculty in 2011 and has pioneered the Vanderbilt Obstetric Drug Dependency Clinic, which is a comprehensive addiction treatment program for pregnant women that incorporates addiction treatment and prenatal care. She's doing a fabulous job. She's spoken regionally and nationally on the issue of drug dependence in pregnancy and is most definitely an advocate for these pregnant women and their families. So with that, Dr. Young.
Thank you. Thanks for having me here. It's so nice to see so many familiar faces out in the audience. I'm going to talk about how we care for these pregnant women and the things that make their prenatal care and their addiction care during pregnancy challenging, and what are some things that we can do better. So to discuss a little bit, put opioid use in context, look at the unique characteristics of women and addiction a little bit, risks of chronic opioid use and abuse in pregnancy, treatment options during pregnancy, and in particular some postpartum issues that are really important to address. So we've been dealing with opioids in the world for a long time. The earliest mention is about 3400 BC, and the role of opioids in society in terms of medical treatment and addiction has really ebbed and flowed throughout the centuries. So in 3400 BC, poppy for opium was cultivated in lower Mesopotamia. And I love this. The Sumerians called it the joy plant. It has always had a particular allure for people. And then in 460 BC, Hippocrates, so father of medicine, taught that opium's usefulness as a narcotic and treatment for diseases of women. I'm not really sure what that was, but diseases of women. And then Alexander the Great introduced opium to India. It was used by Arabs, Greeks, and Romans as a sedative. And then the first documented use to be used for surgery, so as a analgesic for surgery, was about 220 AD in China. And then we skip to 1300s to 1799 AD, and during the Inquisition, opium was banned in Europe as it came from the East, and thus it was associated with the devil. And it wasn't until about the 1500s that in Copenhagen, Paracelsus, who's the father of toxicology, invented an opium preparation, laudanum, which is still available in the United States today. And then that was introduced in England in 1648 and mixed with sherry and herbs. And then in the 1800s is when we really see the use of morphine really increase. So morphine was isolated from opium in 1806, and it really became the mainstay of analgesia and was used for a variety of ailments, used for headaches, used for hysteria, lots of different things. And during the Civil War, that's when it really became widespread, and interestingly, soldiers would come back from the war with morphine addiction, and it was called the soldier's disease. So, and heroin in the late 1800s was manufactured by Bayer, and it was marketed as a cough suppressant and a non-addictive alternative to morphine. So we as a medical community have consistently created drugs that then become problems for our patients. In early 1900s, heroin was marketed as a mail order treatment for morphine addiction. So not a surprise that a morphine addict is going to like to get some heroin in the mail. And around that time, people were starting to get really concerned about the use of opiates and the addictive qualities. And so in 1909, opium was banned from the U.S. for smoking purposes. So there started to be some regulation on recreational use of opium. And In 1914, regulations were legislated that made the prescription and distribution of morphine more difficult. So we've seen that happen in the last few years, our drug databases and things like that, things to make the prescription of narcotic or opiate pills more difficult. In 1916, Bayer stopped mass production of heroin, and oxycodone was invented as a replacement for heroin, so something that was less addictive. I really like this picture of an opium den. Everyone looks really lovely and very relaxed. And so in the 1920s and 30s, heroin was made illegal for all uses. And interestingly, during this time, many physicians used opiates as a treatment for alcoholism. And in 1938, FDA was created, and there were many drugs at that time that were just grandfathered in, so not needing the same studies and risk profiles. And so codeine, oxycodone, and morphine were just grandfathered in at that time. In the 50s, 60s, and 70s, oxycodone became more widely available as Percodan. Heroin made a resurgence during the Vietnam War because heroin was accessible in Vietnam. And so we saw an influx of veterans with heroin addiction coming back from the Vietnam War. In 1969, the WHO clarified that there were important distinctions between opioid dependence and opioid addiction. So even that far back, we've really been struggling with what's the difference between treating someone's pain versus someone becoming addicted to these drugs. In 1973, the Drug Enforcement Agency was created, and Nixon noted that at that time, the U.S. had the largest number of heroin addicts in the world. And then, of course, the 1980s was just say no to drugs. We saw those great slides earlier with Nancy Reagan. Vicodin became available in the 80s. And in the 80s, there was a lot of fear of prescribing of opioids. And there's the term opiophobia that you'll read about. And interesting, at that time, cocaine really surpassed heroin as the most commonly abused drug. So 4 to 5 million people abusing cocaine at that time versus 500,000 abusing heroin. And then in the 90s, we see this pendulum swing again. And so physicians lobbied for more access to opioids for treatment of all pain types. So in the 80s, there was really a restriction of opioids for terminal illness, for cancer pain. And in the 90s, there was this recognition that we weren't really doing a good job as physicians treating pain, and that there were other types of chronic pain that probably needed to be addressed. Under treatment of pain became a real concern, and I think this is important because it helps understand why physicians started prescribing opioids so much. And a lot of that has to do with what was being taught in medical school. So around this time, there was this concern that we weren't treating pain well, and so that started to be addressed in medical schools. There were many more types and formulations of opioids available, and pharmaceutical companies started marketing opioids directly to physicians. And I think it's always important to follow the money, and this is a good example of that. And then by 1999, there were 4 million people who were using prescription drugs for non-medical reasons. Between 2000 to 2009, JCO makes pain the 5th vital sign. And I'm sure many of you who are nurses have experienced that frustration of going in for a post-op patient or just a patient who's in the hospital and their pain score is an 8. And they're talking on their phone and they're not just visibly displaying any signs of pain. And then what happens is you treat them because you have the PRN order that says if their pain scale is greater than 6, they need their hydrocodone or oxycodone or whatever's ordered. Opioid prescribing increases in that 2000 to 2009 period. And in 2002, there were an estimated about 6.2 million Americans who were abusing prescription drugs. And in the mid-2000s, there were companies that were starting to develop opioids that were harder to abuse. So harder to snort, harder to inject because of the extended release formulations, but did not prevent oral abuse. And of course, the rates of neonatal abstinence syndrome in our state really increased during that same time period, and this graph demonstrates that. 2010 to the present, there were very high rates of prescribing, a real lack of consensus among physicians on appropriate doses and appropriate medications for various pain syndromes. There was a high demand from patients, and you will, I think this particularly becomes problematic in rural communities and in places where there are a limited number of physicians and people are seeing a high volume of patients. There also was the rise for-profit clinics for prescription of opiates. And prominent advertising, marketing by pharma. We started to see a lot more drug diversion. And then we see heroin use escalating during this time as pain clinics and prescribing of opiates becomes more regulated. So when you see those laws come into effect, you see that use shift from prescription drugs to heroin. It becomes cheaper and easier to get. So one of my patients told me this last week, it's easier to get drugs than treatment. And I think that's very true. So for women in addiction, the initial use is often precipitated by stress, depression, mental illness, relationships. We've heard about that earlier. Women are more likely to have partners with substance abuse disorder and are more likely to be influenced by a partner's use. So when you ask a woman about how her use of opiates starts, it often starts through a partner. So a partner giving them medication, encouraging them to use it, and that being a part of that relationship. And unfortunately, women with addiction have very high rates of unintended pregnancy. So when you look at the average population, the rate in the United States of unintended pregnancy is about 49 to 51%, depending on which year you look at. And for women with addiction, their unintended pregnancy rate is greater than 90%. And so a lot of that has to do with access to contraception. A lot of it has to do with lack of agency. This idea that things just happen to you and you can't kind of control or make plans. And women, as we heard earlier, who have a history of abuse and violence are more likely to have problems with addiction. So one of the problems, or many problems with opioid dependence in pregnancy, and particularly abuse of opioids in pregnancy, is these women often have a lack of prenatal care. They often have a chaotic lifestyle with subsequent maternal and fetal risks. There's also a higher incidence of abuse, physical abuse, sexual abuse, incarceration, which can become a particular problem during pregnancy because jails typically aren't necessarily equipped to properly treat pregnant women. You'll see prostitution and bartering, exposure to STDs, IV drug use. There are physical complications of opioid dependence in pregnancy. These women have higher rates of miscarriage, higher rates of preterm labor, higher rates of preterm premature rupture of membranes, which ultimately results in preterm delivery, intrauterine growth restriction, stillbirth, neonatal abstinence syndrome, obviously, very increased infectious disease exposure, particularly hepatitis C, Approximately 50 to 60% of my patients have hepatitis C. A lot of other substance use, almost 90% of the patients I see smoke cigarettes, and psychiatric comorbidities, depression, PTSD, anxiety, bipolar disorder. And so the cycle of intoxication and withdrawal in pregnancy is what can be particularly harmful for the pregnancy. So a mother is intoxicated, she gets respiratory depressed, has the potential for aspiration, has the potential for overdose. During that episode, the fetus can become hypoxemic, acidotic. If that's repeating over and over again, it's going to not allow the fetus to grow as well. And in severe cases of intoxication can lead to stillbirth. And then as the mother goes through intoxication and doesn't get that next dose, she can have withdrawal symptoms. And withdrawal symptoms are very physically and metabolically demanding on the maternal system. Increased heart rate, high blood pressure, nausea, vomiting, all over muscle contractions. So if you see a woman who, or any person who's opioid dependent who's in withdrawal, they'll complain of all over body aches. They'll say that they feel like they have the flu. They have a lot of smooth muscle contraction, and so they're going to have nausea, vomiting, diarrhea, but they're also going to have uterine contractions potentially. And so those uterine contractions, they can miscarry early on, they can have preterm labor, all those complications of delivering early, and in severe cases, stillbirth associated with that severe withdrawal. But that's unusual, that doesn't happen very commonly. Tobacco use is 4 times higher compared to other pregnant women in this group. And of course, tobacco exacerbates other complications of opioid use in pregnancy. And alcohol abuse, we do a very poor job screening for, and I think we really don't know how much these women drink alcohol or abuse alcohol in addition to the opiates. It's very hard to screen for alcohol unless someone is coming into your office clearly intoxicated. And all of these drugs combined, benzodiazepines, antipsychotic medications that are being prescribed for mood stabilization, it's unclear what all these working together do to babies and kids long term. So identifying women who are at risk for substance abuse is very important. It's important to screen all pregnant women for substance use. And the ACOG recommendation is to use a validated screening tool. And so what that means is a questionnaire like the Audit C. I prefer 4Ps Plus because it's easy. However, a screening tool does not necessarily mean, and typically doesn't mean, a urine drug screen. And I'll talk a little bit about the problems with just blanketly doing urine drug screens. And in some ways, it's very, it seems like a good idea to do urine drug screens on everyone, but there are some problems with that. The 4Ps Plus tool, you ask 4 questions. You ask if their parents have any problems with drug or alcohol, if their partner has a problem with alcohol or drug use, if in the past they've had difficulties in their life because of alcohol or other drugs, including prescription medications. That's an important part because a lot of people don't consider prescription medications drugs, like illegal drugs. And in the past month, have you drank any alcohol or used other drugs? And a positive to answer to any of those questions is considered a positive screen. And ideally, the provider at that point would have a conversation with the patient about their risk factors, screen them for safety if they're living in a situation where their family members or partner is abusing alcohol or drugs. Talk to them about getting permission to do a urine drug screen, assessing, do they need to be referred to for a drug and alcohol assessment. I recommend universal screening at their first OB visit and when they present to labor and delivery. By screening everyone with a screening tool, you eliminate provider bias and assumptions, allows for early intervention and education. And then, so routine urine drug screens. And so that means like everyone who comes for their prenatal visit or everyone who presents to L&D gets a urine drug screen. That would be perhaps okay if we do that for everyone, but what tends to happen is we tend to target people that we suspect. So if someone is coming into the hospital in preterm labor because they've been withdrawing because they haven't used in 3 or 4 days, you might get a negative screen. And that could potentially cause you not to screen baby, or you can miss something. So we have to be careful about relying too much on urine drug screening. Also, urine drug screening has very real implications in the state of Tennessee with the legal environment we are in. So a woman could get prosecuted based on a positive screen at any point in pregnancy. So there are a lot of barriers to treatment, and this is something that we could do much better in my personal opinion. There is fear. So patients fear disclosing their drug use to their doctors. They fear that they will get arrested. They fear they will have their babies taken away. They fear that they will be judged. It takes a lot of courage for someone to take that initial step during pregnancy to admit they have a problem to all these people in authority and trust that they're not going to be, that's not going to be used against them, that they're not going to be treated badly. So that's very difficult for patients. There's a lot of stigma. What this leads to is people attempt to self-detox at home. So they think, I have a problem, I don't want to be using these drugs during pregnancy, so I'm going to stop on my own. And so they try to stop, and they have withdrawal symptoms. And so then they use again. And then they try to stop, and they have withdrawal symptoms, and they're worried about miscarrying, and they use again. And so they go through that cycle many, many times before they realize that they can't really do it on their own, and they need to seek further care. There are a serious lack of programs. Well, there's a lack of programs at baseline for all people, but a real lack of programs for that accept pregnant women. And so what I find is that in my clinic, we see patients that travel for 2.5 hours away because there is no facility in their county that will provide drug addiction for pregnant women. There are no OB doctors that will even do their prenatal care in their county, or at least the patient perceives that to be the case, whether or not that's true. There is insurance and cost. A lot of people have very poor access to transportation. They have to travel a long way. A lot of these patients don't have insurance until they get pregnant, and so they don't even have any access to get any sort of treatment prior to pregnancy, pretty much. There's child care issues. So if they are a single parent and have 2 other kids at home, it's very unlikely that they're going to be able to go into an inpatient rehab facility if they don't have anyone to take care of their kids, anyone that they trust to take care of their kids. And then often lack of family and social support. And that can go both ways. It can be that other people in their family use and enable their use. It can go the opposite direction where no one in their family knows that they use, or their partner knows that they use, but it causes a lot of stress in their relationship, and their partner doesn't want them to get treatment. The partner just wants them to stop. Like, why can't you stop? It's kind of the, and so a lot of things make it difficult for people to get care. The recommendation is that pregnant women who are opioid dependent have a comprehensive treatment program, ideally a program that incorporates OB, psychiatry, social work, case managers, anesthesiology for the labor and delivery part, nutrition, counselors, peer support, pediatrics, legal aid, lots of services that are needed. And it's very important to develop a therapeutic alliance with a patient. If a patient doesn't trust you, they're not going to be able to make all the kind of lifestyle changes. They're not going to feel like they can engage with you if they think that every step that they take, they're at risk for being punished, reported to DCS, all those sorts of things. And we know that patients have improved outcomes if they receive integrated prenatal care and substance abuse treatment. Ideally, these women would be seen, and this is kind of at an outpatient, well, this is an outpatient setting. So obviously there are people that need much more intensive treatment programs, and a lot of people would benefit from the comprehensive residential programs like they have at Renewal House and that sort of thing. But at the very least, weekly or biweekly visits, individual counseling, group meetings, peer support, that ideally it would be great to have more intensive outpatient programs available for these patients, so that there is a kind of medium between inpatient treatment to just kind of true outpatient visits. Urine drug testing is an important tool in this environment to monitor for how effective the treatment is. And it can often be a way to identify that there are problems going on before the patient is kind of ready to bring that up. From the OB side, we do serial growth ultrasounds to make sure baby's growing well. We do that about every 3 to 4 weeks after 24 weeks of pregnancy. And then if baby isn't growing well, that's when we do twice weekly testing and that sort of thing. So the benefits of combining care, it's one stop, requires less travel, and ideally would improve care coordination. They tend to miss fewer visits, and particularly when moms are being treated with medication-assisted therapy like buprenorphine or methadone, they're much more likely to keep their addiction treatment appointment than their OB appointment if they're having to choose between rides and that sort of thing. And it really just allows integration of support and counseling services. So in terms of actually treating opioid dependence in pregnancy, opioid maintenance is the standard of care. So, and this is important because a lot of people think, well, why don't we just detox these people? Like if we just detox them, we wouldn't have the NAS problem. It would solve that. You know, they wouldn't be on drugs anymore. Everyone would be happy. But the problem is that detoxification is often not successful. So there aren't a lot of great studies on this, and so this is an area that really needs to be researched more. But the general sense is that about 30% of women who are detoxed resume using street drugs as soon as they're discharged. So you go through all that process of detoxing and then it just doesn't work. 12% of these women who are successfully detoxed in this study opted to go on methadone maintenance after they were discharged from the hospital. So realizing that the stressors in their life were too much, they were too worried they were going to relapse, and so they opted to go on methadone. And then in this study, which is very concerning, is that 25% of patients who were detoxed had withdrawal so severe that it precipitated preterm labor. So we're very concerned, obviously, about the morbidities of delivering a preterm baby. You know, particularly you're talking 24, 25, 26 weeks. It's not something that we want to do. Opioid detoxification can be done. If it's done, ideally it's done as an inpatient, particularly if they're further on in pregnancy. It is typically tapered with methadone and buprenorphine, and that's called methadone or buprenorphine assisted withdrawal. And outcomes are better for women who are in a residential treatment program. So women who are detoxed completely and then go to a residential program as opposed to going back to their community where everyone else uses and the temptations for using are very great. There was a study in 2013 that got everyone really excited about opioid detoxification of pregnancy. It was a retrospective study, looked at 95 women. Of those 95, there were 53 women who were successfully detoxed. So tapered off their opioids and then not on anything for the rest of the pregnancy. Of those women that were successfully detoxed, 5% of the babies whose moms were successfully detoxed were treated for withdrawal, and 33% of the babies whose moms weren't detoxed had withdrawal. So much better in terms of the NAS. However, the average length of stay for these women was 25 days. And I can't speak for the hospitals that you're associated with, but my hospital doesn't want to keep women in the hospital for 25 days to detox. And I imagine that's true for most places. And then the study also had a lot of exclusion criteria. So these people could never have failed detox before. They couldn't have a baby that was IUGR. They couldn't have low fluid. They couldn't have any significant maternal psychiatric illness. And every patient I see has a significant maternal psychiatric illness, pretty much. And so these people were really ideal candidates, and yet only about half of them were able to be successfully detoxed. So it can be done, but probably not everyone is a great candidate for that. Of course, it reduces NAS, it reduces long-term effects of opioid exposure, theoretically. By many people in the addiction treatment community, it's considered true recovery. And what women will tell you is that if they're on methadone maintenance or buprenorphine maintenance, a lot of fellow addicts that they're in treatment with, a lot of addiction treatment providers tell them, oh, you're not really in recovery because you're on this maintenance medication. A lot of their family members don't consider that true recovery. So there's a lot of pressure to be completely detoxed. And it also decreases the risk of child protective services and legal action. The disadvantages, there are a lack of evidence-based protocols, there's high risk of relapse, shortage of drug treatment programs that can really do this right. There are risk of withdrawal symptoms if it's not done correctly. If you taper a patient in 3 days in jail, probably not a good idea. Seen that happen before. And it requires a large degree of financial and institutional commitment. And of course, we all know there just aren't enough residential programs. So that leaves us with maintenance-assisted therapy. And so for decades, methadone maintenance was the gold standard for opioid addiction. And it has been shown to increase adherence to prenatal care, improves pregnancy outcomes in general. Some studies say it decreases the severity of NAS, but you're probably at that point looking at heroin users and people who are kind of in the extreme of the spectrum. And it decreases foster home placement. It requires a visit to a methadone clinic every single day. So the only place where you can legally get methadone for the treatment of addiction is at a licensed methadone clinic. And there are 2 of those. There's one here in Nashville and there's one in Columbia. Any physician can prescribe methadone for chronic pain. However, it is typically not the same dose as someone would need to treat addiction. And legally, you cannot treat addiction with morphine, with methadone as an individual provider, although I've seen that happen also. And you basically start them on a low dose, you titrate them up and to eliminate withdrawal symptoms without producing intoxication. The disadvantage of methadone is it requires a daily visit to a treatment center. It has cost, insurance doesn't cover it, so people are paying out of pocket, often $75 a week or so. There's a lot of stigma about going to methadone clinic. There's continued exposure to others who are using often. And then the incidence of neonatal abstinence syndrome is still about 50 to 66%, depending on what study you look at. And a lot of my pediatric colleagues will have told me that they would prefer to detox or to have a baby exposed to buprenorphine compared to methadone, just because they tend to have to get treated longer and with higher doses and that sort of thing. So buprenorphine maintenance is something that is newer in pregnancy and newer in general. It's a partial mu opioid agonist and a full kappa opioid agonist. And so it blocks the receptors, the opioid receptors in the brain, without activating them and causing the euphoria that a full agonist like heroin or oxycodone does. There was a randomized controlled trial, the Mother trial, that showed that neonatal outcomes are similar to methadone, and so that's what kind of really prompted people to start using buprenorphine in pregnancy, often associated with less severe NAS and less morphine requirement. It's an office-based treatment, which really frees people from having to go to a methadone clinic every day, which can be a big barrier if you're having to drive 2 hours. And there's more insurance coverage for buprenorphine maintenance. And patients will tell you, if they're taking it right, if they're taking it correctly, that they don't feel like they're on anything. They don't feel high, they feel normal. Unfortunately, that means the relapse rate is often higher on buprenorphine than on methadone, because for many of these women, normal is not good. And it can cause you to think about some things that you probably didn't want to be thinking about. If they're on buprenorphine prior to pregnancy, you just continue them on that. And they may need an increased dose during the 3rd trimester. However, to start a pregnant woman on buprenorphine, they have to be in moderate withdrawal. So if they are not in moderate withdrawal, if they have used an opiate recently, by giving them buprenorphine, you can put them in severe withdrawal. And that can be very dangerous for them for the pregnancy. So they have to be at least 6 hours since their last dose of short-acting opioid, at least 24 since their last dose of a long-acting opioid, and they need to be exhibiting moderate withdrawal symptoms. And you start low and you titrate up. Disadvantages: there are no rigorous studies on initiation during pregnancy. It's often not effective for women who use high doses of IV drugs, so particularly for women who abuse heroin. There was a higher dropout rate in the Mother trial, though it wasn't statistically significant in that study. And not every physician can prescribe this. So physicians have to obtain a waiver from the DEA to be able to prescribe buprenorphine. Chronic pain in pregnancy is a whole different thing, and I think there's a lot in art and difficulty in figuring out if someone has true chronic pain, whether they have they're abusing opiates, whether it's both, and a lot of time it overlaps, so that can be very difficult. But in the few studies that have just looked at this population, this chronic pain population, there is some thought that these babies are less likely to experience NAS than a population of women who are addicted to opiates. So the general recommendation for that population is that their treatment plans must be individualized. Tapering can be done with caution. You just really have to do a lot of individual treatment plans. So what I've started to see more and more is women with chronic pain who have never abused their opiates who get put on buprenorphine. And these are women who use short-acting opiates like Percocet, Lortab, that's prescribed, never had a problem with overuse or abuse, are on small doses, 5 to 10 milligrams twice a day maybe, and then they get, I think, mistakenly put on buprenorphine by well-intentioned physicians, thinking that it's the best thing for them to do. But the problem is that buprenorphine doesn't treat their pain and probably puts baby at more risk for NAS when you're comparing it to very small doses of short-acting opiates. And you're lumping them in a category of people that potentially puts them at risk for a lot of bias. So, and there's been it's never been shown that maintenance-assisted therapy, like with methadone or buprenorphine, is beneficial in that population. But of course, a person with chronic pain, they have to be ruled out for having addiction. Postpartum, it's important that a plan for continued addiction treatment is made. We discourage detoxification in the immediate postpartum period because that's such a stressful time. Often they'll have, or sometimes they'll have babies in the NICU. It's not really a time for them to be detoxified. They're at high risk for postpartum depression. If they're going to a methadone treatment facility, they can get financially detoxed if they haven't kept up with their bill. So that's something to be aware of. Contraception is very important. So we try to discuss it as often as possible. And we're lucky to have a grant that enables us to place IUDs and Nexplanon inpatient for this patient population. That way, if they miss their postpartum visit and they want a long-acting reversible contraceptive, they have that ability. Breastfeeding is generally safe for women who are maintained on methadone or buprenorphine and should be supported unless they're actively using other drugs, unless they're on other prescribed medication where it's contraindicated. It can be very beneficial for mother-infant bonding for the right candidates. Relapse is very common, and if you look at opiate addiction compared to other chronic diseases like hypertension, asthma, type 1 diabetes, you'll see that it's very similar. Relapse rates are similar among all of those. And so does relapse to drug abuse mean treatment has failed? No. The chronic nature of the disease means that relapsing to drug abuse at some point is not only possible, but likely. And what matters is what they do with that. What matters is how engaged that they continue to be in their treatment program. Are they able to tell their physician, their counselor, that this has happened? Or are they just reacting out of fear and they're unable to kind of be honest with where they're at in their treatment? So what relapse means is that treatment needs to be reinstated. If they're not currently in treatment, it needs to be adjusted, it needs to be changed. You need to increase the behavioral therapy, increase their support, look at underlying stressors and triggers. And I think I'm out of time, so I'm gonna just, I like this Chinese proverb, the best time to plant a tree was 20 years ago, the second best time is now. So it would be great if we could go back in time and fix all the problems that caused this epidemic in our community, but we have a lot of opportunity to do better with what we do now.